While treatment advances and vaccine efforts may be successful eventually, lockdown measures cannot be prolonged until we find treatments and vaccines that save many lives, since such breakthroughs may take a long time or may even never happen. For example, remdesivir has shown promising results in shortening disease duration, but no conclusive evidence yet for saving lives. Thank you for listening.
Thank you, Dr. Iaonnidis. Before we go back to Mr. Roy, we'll do our last witness, Dr. Scott Atlas, testify. Dr. Atlas is the David and Joan Traytel Senior Fellow at the Hoover Institution at Stanford University and a member of the Hoover Institution's Working Group on Healthcare Policy. Prior to joining the Hoover Institution, Dr. Atlas was professor and chief of neuroradiology at Stanford University Medical Center for 14 years. He received an MD from the University of Chicago School of Medicine. Dr. Atlas.
Okay, thank you, Mr. Chairman, and thank you for inviting me to speak here today. As we all know, the consequences of the COVID-19 pandemic, of course, have been enormous. That said, the direct daily toll from the infection has markedly declined, including in the epicenter, New York. The curves have been flattened. The stated goal of the isolation has been accomplished for both hospitalizations per day and death per day, the two curves that needed to be flattened. We now, though, have an even greater urgency, specifically due to the extension of the severe single-minded policies already implemented. Treating COVID-19 at all costs is severely restricting other medical care and instilling fear in the public, creating a massive health disaster, in addition to the severe economic harms that would generate a world poverty crisis with incalculable consequences. Half of neurosurgery patients still today refuse to come in for treatment of disease that, if left untreated, risk brain hemorrhage, paralysis, and death, even when their doctors directly reassure them because of the fear. Transplants from living donors are down 85% from last year. In the US alone, 150,000 new cancer cases arise every single month. These patients are not being seen. Biopsies of unknown, undiscovered possible cancers number thousands per week. They're not being done. That doesn't include the latest reports of skipping 2/3 to 3/4 of cancer screening tests, most childhood vaccinations, and treatments for emergency new strokes and known cancer chemotherapy. One more thing we absolutely know is that this total isolation policy prevents broad population immunity. We know from decades of neuroscience, of medical science, that the population develops immunity while acquiring antibodies. Indeed, that is the main purpose of widespread immunization, to assist with herd immunity. In the COVID epicenter of New York, undoubtedly muted by the extreme policies, we still see that more than 24% of those tested have antibodies, and a similar finding was reported in Boston. That fact has been incorrectly portrayed to the public as an urgent problem requiring mass isolation. But on the contrary, infected people are the immediately available vehicle for establishing widespread immunity among low-risk groups. While we do not know with certainty that antibodies stop infection, it is expected based upon decades of virology science, including with other coronavirus respiratory viruses. That's exactly why scientists are hopeful about using COVID-19 antibodies to treat the sickest patients. That's the basis for the drive to generate a vaccine. Reassuring the public about re-entry is critical, and it requires repeating the facts, what we know about the threat and who it targets. By now, as Dr. Iaonnidis implied, multiple studies from all over the world suggest that the overall fatality rate is far lower than early estimates, and those were the estimates that motivated the extreme isolation. We also now know who to protect, because this disease, by the data, is not equally dangerous across the population. For example, in Detroit's Oakland County, 75% of deaths were those over 70, 91% over 60. Similar findings of New York. Again, healthier, younger people have virtually no risk of death and almost no risk of serious disease, and similarly, highly unlikely to be hospitalized. Here are specific science-based logical steps strategically and safely restore the pathway to normal life. First, we must finally focus on protecting the known most vulnerable. That specifically is nursing home patients. Given that older people with underlying conditions were always the obvious setups for serious complications from respiratory diseases like this, it is difficult to even excuse policies that allowed almost 30% of US deaths to die in nursing homes, more than half in some states, particularly when they already live in controlled access. This is an urgent need and probably too late to help for most people. But targeted, strict regulation of all who enter, including mandatory testing for these people, must be done. We must continue to educate and inform the public about what they have already learned regarding at-risk age groups and how to deal with them. In addition to the standards of hygiene and appropriate social distancing that we already know, that has to be reinforced, and we know that people can do it. That's what's being done. Second, those with mild symptoms of the illness should strictly self-isolate for 2 weeks. It's absolutely not urgent to test them. We assume they have the infection at this point. That includes confinement at home, having the highest concerns for sanitization, wearing masks when others in their homes enter their room. Third, K through 12 schools should be opened. If under 18 and in good health, you have virtually no risk of serious illness. Exceptions exist, as they do with every single clinically encountered infection, but that does not outweigh and cannot outweigh the overwhelming evidence to the contrary. Again, standards for consciously protecting elderly and other at-risk family members and friends, including the teachers in high-risk groups, should still be employed. Fourth, most businesses can be opened, including restaurants and offices, but of course we require new standards for hygiene and sanitization with more stringent regulations than we've had. It is reasonable to post warnings for customers who are older or in other ways at risk. And indeed, we already see businesses and workplaces setting up such environments because they already understand the obvious need to allay fears of workers and customers in order to regain function. However, it is not logical that younger age groups must somehow be isolated or maintain a 6-foot spacing from each other. If infection in low-risk groups is still prevalent, which it is, socializing represents the opportunity for developing the widespread immunity, eradicating the threat to the vulnerable. Fifth, public transportation, which is the lifeblood of much of the workforce, should resume. In addition to the standards of cleanliness and hygiene that passengers would welcome, of course, regional authorities could require things like barrier masks for passengers. Given the state of our fearful public, it is highly likely that most people will choose to wear them. Similarly, air travel hygiene has already been improved, and further changes are likely regardless of any requirement because travelers will simply not have the confidence to fly. 6, parks and beaches should be open. There is no scientific reason to insist that people remain indoors. Given now that we know who to protect and how to protect them even inside our homes, outdoor activities can resume with smart, considered limits on large group gatherings. Finally, prioritized testing is important, but it's important in 3 specific groups: nursing home workers, healthcare workers and first responders, and patients in hospitals with respiratory symptoms or fever. Widespread testing for the entire population is not a predicate for reopening as above with these guidelines. And contact tracing, although an important part of the overall preparation for potential future outbreaks, is not critical right now and is not as valuable after a disease is already widespread, infecting tens of millions of people. In summary, targeted protection for the known vulnerable, standards and common sense recommendations for individuals and businesses, and prioritized testing are the basis of an urgently needed strategic re-entry plan that would save lives, prevent overcrowding of hospitals, and limit what are the enormous harms compounded by continued total isolation. Smart, safe re-entry cannot be delayed by fear or hypothetical projections. We have direct data on risk, and we have now experience with managing it. The goal of the strict isolation has been accomplished. We need to stop underemphasizing the actual empirical data and establish medical science while instead somehow doubling down on hypothetical models. Science and logic must prevail over fear in worst-case scenarios. Thank you.